Today, I'm so delighted to be in conversation with Dr. Louise Newson, who's a GP and menopause specialist from the UK. She's the founder of the Balance app, the menopause charity, Newson Health Research and Education, the Dr. Louise Newson podcast, and a member of the UK Government Menopause Task Force. Before we jump into this conversation with Louise, I thought it might be helpful for everyone listening if I just review a few points and facts about the menopause and the perimenopause and what it is. So first of all, 51% of the population will go through the menopause. That is, all women will go through the menopause. And for the other 49% who have a mother, sister, partner, daughter, it's probably a really good idea that you would understand something about it too. So I'm really hoping that everybody will gain something from today's episode. So first of all, what is the perimenopause? It's the stage of life leading up to your last menstrual period. And that is a period of lots of hormonal fluctuations. And it's actually a period of time that women have a lot of symptoms, sometimes. And other times women sail through the whole process and there's not much of a drama. So that is the perimenopause. I will talk in a little minute about the symptoms, but let's just get these definitions out of the way first. The next thing is menopause. And in actual fact, menopause in theory is 1 day. So it is, you're diagnosed officially as having had the menopause exactly 12 months after your last period, which is a little bit bizarre because there's not much else in medicine where you have to wait 12 months to get a diagnosis of something. But anyway, at some point, someone decided to make that the definition. So in theory, menopause is 1 day. And then the postmenopause is everything after the menopause. And the postmenopause actually doesn't end. And why is everyone talking about the menopause and postmenopause? Well, I've heard a few people say things like, "Oh, it's natural, so why are we medicalizing it?" But the reality is that we actually, I suppose, medicalize a lot of things. You know, childbirth's natural, but we still involve midwives and doctors, and we give people pain relief, and that's a pretty humane thing to do. And lots of disease processes in theory are natural, and yet we still give people treatment, and we're very empathetic about their journey with that illness. And so although the menopause is in theory a natural sort of biological phenomenon, it's not something that doesn't come without its issues. So in all women after the menopause, there is quite an increased risk of things like osteoporosis, which is a thinning of the bones. So what we know is that our hormones really keep the balance of our bones in check, and estrogen is very, very important for this. I know people sometimes think of a bone as being this sort of solid lump of hard calcium, and it's very rigid, but actually bone is something that's being laid down and reabsorbed constantly. And after the menopause, that balance goes off and you're reabsorbing more bone than you're making, and it makes the bones porous and makes women or anyone who has osteoporosis much more prone to fractures. And they may be big fractures that require surgery, or they may be little cracks in the bone that just cause a lot of pain. The other thing after the menopause is the risk of heart disease in women goes up really very dramatically. And we know that our hormones are very protective. So before the menopause, women have actually a very much lower rate of heart disease than men. And then that very, very quickly changes after the menopause. So we know again that there's something going on, and most of the theories are around that very anti-inflammatory capacity of our hormones, which then is lost after the menopause. And then the third issue that a lot of women will go on to have after the menopause is dementia. And we know again, after we lose our hormones, the rate and risk of dementia increases. And women who have an earlier menopause or who are longer without their hormones are at increased risk of dementia. So there are real health implications to going through the menopause and being postmenopausal. So even if you're lucky enough to sail through the perimenopause, and I hope for you that you are one of those people or your family member is, and that's amazing, but it doesn't change the fact that everyone then develops the risk of these three main categories of health problems. And then if we talk about the perimenopause and what that means, so as I said, the perimenopause is that stage of life leading up to the last menstrual period. And that this perimenopause phase can last, anything up to 10 years. And the average age of menopause in Australia is about 51. So in theory, this can begin in the early 40s. But again, 51 is an average age. So you could potentially be perimenopausal in your 30s and have a menopause in your 40s. And then, of course, we also have to remember the people who've had surgical menopause because they've had their ovaries removed. And the reason that the perimenopause, I think, is getting more and more conversations at the minute is because I think, people are really beginning to realize that there's such health problems associated with this period of time. And depending on where you look and read, there's all sorts of lists that tell you the symptoms of the perimenopause. Some say there's, 29 symptoms. Some say there's 34. But what I can tell you is there are definitely a lot of symptoms. And in both my GP clinic, in my aesthetic clinic, and also just chatting to friends and other school mums and things, it comes very apparent that lots of people are finding various things very, very difficult. So some of the symptoms, that tended to get a lot of publicity, and everyone talks about hot flushes. But what I will tell you is that although this is a symptom, it's definitely not the commonest symptom that comes through the door to me. Symptoms that will be further up people's complaint list are things like fatigue, not being able to sleep well, brain fog, feeling like they're thinking through maple syrup, they just can't find words, anxiety that they'd maybe never had before, joint pain, muscle pain, frozen shoulders, burning tongues, itchy skin, dry skin, recurrent urinary tract infections, drop off in sex drive, sex being really painful, palpitations, feeling just generally unwell, feeling detached from your family members. So, that's just a short collection of some of the symptoms. There are so many more. And I think for anyone listening, even if this is a phase that's not where you are right now, at some point, if you're female, then you will end up there, or you've probably been there. And if you're male, you're very likely to have someone in your life who's going to potentially have this as a problem. And I think what I'd really love to achieve by our podcast is that we are empowering people to perhaps be prepared, so that if you do find yourself in a bit of a dark space where your mood has dropped off, or you're feeling irritable or anxious, or your sex drive has dropped off and your relationship is in jeopardy, that you might just have a little bit of a light bulb moment and go, oh, I remember hearing about this, and I know that there are things that we can do to help. Because the really great thing about all of these problems is the vast majority of them respond really, really well to those hormones being replaced. And it's quite a simple thing to do. Sometimes it takes us a little bit of time to get the dose quite right, but it's definitely very, very manageable. And what I see all the time is people's lives being really transformed by replacing those hormones. Not only are they going to improve those symptoms that they're having, but by replacing those hormones, then you're going to really reduce the risk of those issues that I discussed earlier, those thinning bones, the osteoporosis, the heart disease, and that risk of dementia later in life. Now, of course, not every single person in theory is suitable for hormones. And there are some people that we would really have a big discussion about, if that's the right thing for them to do based on their other health conditions. But what I do believe really strongly is that every woman should be entitled to have the conversation and to do their own research and come and pick the brains of as many professionals as they need to be able to make the best decision for them. Because ultimately, you know how you feel, and you know what is worth the risk for you and what isn't. So with all that said and done, I'm going to jump right into my conversation with Louise. I hope it's helpful. We do talk a little bit about a couple of topics that some people may not have heard of. One of them is the WHI. And that's a study that came out about 20 years ago, and it really caused the downfall of people using HRT, and in more recent years has kind of been debunked and felt not to be accurate. So if you hear us talking about WHI, that's what we're talking about, that old study. Louise does also come from the UK, so she does refer to a few UK government bodies and guidelines, but hopefully it'll all make sense once we get in there. Anyway, I really hope you're going to enjoy this episode. Louise is a fountain of knowledge, and I absolutely love this conversation. Let's get into it. Welcome to All About You. Thank you so much for joining us. It would be lovely if you could tell my listeners a little bit about you. There will be some of them who'll definitely know you. You're quite famous here in Australia, especially among all the UK and Irish people who live here. But there's obviously lots of people who haven't heard of the Menopause Doctor. So it would be lovely for you to tell us a little bit about how you've ended up where you are today.
Yeah, thank you. And thanks for inviting me to the podcast. I didn't dream and envisage that I would do what I'm doing now, actually. So I've got a background of hospital medicine. I wanted to do oncology. So I wanted to be a cancer specialist, actually. And I've also got a pathology degree. So I really enjoy basic science. And I did all my qualifications in hospital. I met my husband when I was 18 in Freshers Week, first week at medical school, and he's a surgeon. And we were at a sort of pinch point in our careers where we were doing the next level of becoming more senior doctors. And the on-call was busy and hard. We were both full-time. We just got married. And I tried to find a female role model, and I still can't find one, actually, but that's another story. And I thought, oh, how is it going to happen with two of us doing on-call? If we're managed and are blessed to have children, it's going to be really difficult. And I always wanted to bring my children up rather than farm them off with different carers. So I decided to go into general practice, which was great, had a fantastic trainer, and then did general practice, but I did it part-time to fit in with my children, and the rest of the time I was a medical writer and medical educationalist, and did a lot of writing, not just for healthcare professionals, summarising the evidence for them, but also for non-healthcare professionals, so for patients. And a lot of my writing work, this makes me sound very old, which I am, was before the internet came out. So we didn't have Dr. Google. So I really feel very strongly that people should be empowered with information, but it has to be the right information. So I realised quite quickly that the more information people have, the better informed decisions they can make about their future treatments. So I did that for many years. I've always enjoyed prescribing HRT because it's, as you know, one of the most transformational medicines to give. But it's not really a medicine, it's just hormones. And I've always been told off for it by my partners at work, were saying, that's so dangerous, what are you doing? And I said, it's not dangerous. I'm improving the quality of their life and reducing their risk of future disease. And we'd have sort of various quite heated rows, actually, about HRT. And then the NICE guidance in the UK came out 8 years ago, which showed top line benefits outweigh the risks for the majority of women of HRT. And then the International Menopause Society guidelines, as you know, came out in 2016. Around that time, I was mid-40s. A lot of my friends were coming out of their doctors being given citalopram, venlafaxine, sertraline, antidepressants for their menopausal symptoms. And I said, well, no, you need some hormones because it will not only improve your symptoms, but improve your future health. And they said, oh, no, the GP won't prescribe it. So then I thought, this is awful. So I set up a clinic really on my own, just one day a week, to try and help some of my friends and school mums and people. But I also, because of my writings, decided to develop a website, which was then called Menopause Doctor. I then started to play with social media and also play with them, not play, but involve the media more, thinking they've got it wrong for 20 years, telling women all the potential risks of HRT, which we know a lot of it's from unfounded evidence. So it sort of just helicoptered into this space where 5 years ago I opened a dedicated clinic where I have over 110 clinicians that work with me. We see thousands of women a month who are all underserved by the NHS, but I also developed the Balance app, which is a free app which has a global reach, and education program as well for healthcare professionals. So I didn't realise when I started that the 1.2 billion menopausal women worldwide are so underserved and undertreated. So yes, the work has escalated, but it's a collaborative work. I work with some amazing people, and we're starting to see that we are making a difference, which is really rewarding.
Well, that's one of the things I was going to say. It would seem that the perimenopause and the menopause are having a moment, as it were. It's all over the media. It's certainly, I think Australia's probably a little bit behind, but there's obviously been a lot of movement in the UK with government being involved in things. And obviously it's trailblazers like you that have really pushed this forward. But why do you think it's sort of happened now?
Yes, yeah, I think people are listening, but one of my worries, I worry a lot really about the injustice to women, but one of the problems is that there's a lot of talk about it, but there's still not enough action. I mean, even having come back from Australia, I can't begin to tell you the number of messages I get from women in Australia saying, I've listened to your podcast with the Imperfects. It was the most amazing thing. I cried all the way through, but now I don't know how to get help. And that's the problem. And that's what we've been facing over here as well, is that women are waking up and understanding, but actually the policymakers and the healthcare professionals are not so quick to embrace this. So there's a real imbalance between what women want and need and what they can obtain.
There is so many symptoms that we're now realizing are related to hormones, and people are often sort of blown away by all the things that we can attribute to the perimenopause and the postmenopause. I just wonder whether we could chat through some of the symptoms that are maybe the more unusual ones that people don't particularly think about. Like, everybody always thinks menopause and hot flushes, but as someone who had the menopause at 34, I have to say I never had any hot flushes at all. That was not a symptom for me. Can you talk a little bit about some of the other symptoms that perhaps are an issue?
Yeah, for sure. When we look at the thousands of people that monitor symptoms through Balance app, we see that the commonest symptoms are the ones affecting our brains. So symptoms of low mood, anxiety, memory problems, fatigue, poor sleep. Also, a lot of people say they just feel joyless, they feel flat, they just aren't interested in life in the same way. Then there are other physical symptoms, so joint pains, muscle aches, headaches, dry skin, itchy skin can be very common. The hot flushes and sweats do occur, but not as commonly as people think. And every day we read menopause equals hot flushes and sweats. And also there's always a talk about vaginal dryness, which is very, very common, but it's not just dryness. It can be soreness, it can be discomfort. But it associated with those symptoms or alone is often urinary symptoms. So people can have increased frequency of passing urine, they might have some leakage, they might have increased risk of urinary tract infections. And those are often not thought to be related to hormones, and we know that they are. So it's really important that people can pick up on symptoms themselves. And some women have lots of symptoms, some women might just have one or two symptoms, or the symptoms might change with time as well.
And whenever you think about sort of those genitoury urinary symptoms, one of the issues that a lot of people come and see me as a GP, they'll often talk about issues having sex, how painful it's become, how it's uncomfortable. And that causes definitely a lot of anxiety as well around their relationship and, if their partner's going to leave them. Is that something that you're seeing a lot of as well?
Yeah, we see a lot. Certainly in our clinic, we do the symptom questionnaire, the one that's on the Balance app and website. all the time. And actually, because it's got libido on it, people know that we might be talking about sex if it's appropriate. And most women, when I see and speak to them in the clinic, say they haven't had sex for many months, sometimes years. And it's not because they don't love their partner, it's often because they don't have any libido, but also it's very painful if they do. But they don't know how to get treatment. And we know that from studies that we've done. We did a study of 2,000 women recently, and we found that over 50% of women said that it was the menopause that was affecting their sex life, but they were very sad about it. So it's not like women are choosing not to have sex. They just don't have the same urge, and it's not pleasant when they do it. So you can realize why it's happening. But what's really sad is that 25% of people said that they couldn't talk to their partner about the way they were feeling. And I see it all the time that a lot of relationships are breaking down. And we know divorce rate increases in women in the 40s. And it's really important, as doctors, we don't mind talking about sex, but a lot of people find it very uncomfortable. But in a consultation, once we talk about it, they actually find it really lovely that they have got a safe space to talk and not be judged. And I think it's incredibly important that we do that with our patients when it's appropriate.
Absolutely. I don't know about you. I went to medical school from 1994 to 1999. I don't really remember anyone particularly teaching me how to ask people those questions, or in fact really teach me anything at all about the perimenopause and menopause, other than ovaries. It was ovarian failure, and that was that kind of thing. And if you didn't have some hot flushes, well, then you didn't really need to do anything. And obviously we're now realizing that that's not true. Whenever I graduated from medical school, pretty quickly into my career, there was obviously all these studies that came out, and the next thing, HRT prescribing really, really plummeted. And I think a lot of doctors have become really de-skilled and quite nervous about it. And, the availability of different types of HRT, I think, really shrunk. And I think, it's going to be a real process to try and get doctors who are already really busy to get them motivated enough to re-educate themselves. And I know that you've worked really, really hard to provide that platform, which I've absolutely loved working through. But I know that you've just revamped your education program. Can you tell me a little bit about that?
Yeah, so I'm exactly the same. I'm older than you and qualified in 94. So I started medical school in 1988 and didn't have any menopause education at all. And when I was training, what I learned the most actually was sitting in with other people's consultations to hear how it works. I can read all the papers, but it's not the same as how do you prescribe? How do you individualize? How do you talk to the women in the right way? And so when I designed our education program many years ago, it was actually before COVID, I decided to film some consultations where myself and some of the colleagues I work with were filmed with actresses who had different cases. So there's, someone with cancer, someone who's had migraine, someone who's young, someone who has urinary symptoms, who's older. So there's a whole spectrum of different clinical scenarios that people can work out of. And we've linked to the available evidence, so the references, the articles, but also to patient resources as well. And then we've got some lectures by other experts as well, talking about different areas. And so we filmed it all so people can do it remotely, but also have a feedback as well, so that they can do some questions before and after. So you've got a constant assessment, and then you get a certificate at the end. And we relaunched it not long ago, actually, a few months ago, and we've already had over 2,000 downloads of it, which is great. The previous course was similar, but we've just revamped it and made it better. The previous one, we had over 30,000 downloads of it. So it shows that healthcare professionals really want to learn more, and it's a global thing. We've had lots of healthcare professionals from many different countries actually accessing the course.
In collaboration with this podcast and my clinic, You by Dr. Shauna Watts, we have a challenge for you. For the month of February, it's called Leap into 2024, and this is all about your health and wellness. It's simple, it's evidence-based, it's free to join, and we've some major prizes up for grabs. So head to our Instagram for all the details. Now, let's get back to this episode. And Louise, is this a course that you're happy for patients to sign up and do as well?
Absolutely. No, we've made it so that it's accessible for everybody. When we do some of the describing about, this is Mrs. X with migraines, we've actually written for non-healthcare professionals as well. So to give an explanation what migraines are and that sort of thing. So we've made it so that anybody, so whether they're a healthcare professional or not, or quite a few people who are nutritionists or maybe yoga teachers, or helping menopausal women in other ways, but also patients can. I feel very strongly that patients should know as much as we do if they want to. It's very patriarchal medicine. It's very much you do what the doctor tells you. But I really feel that we shouldn't be acting like that. And as you know, we get far more rewarding consultations when people are empowered, because I feel as a doctor, I'm patient's advocate. I'm not there as a dictator. I'm not telling them what they should and shouldn't do. But I really feel that they should be empowered with knowledge, and then we can decide together what's the best appropriate action and treatment for them.
Yeah, absolutely. I mean, when I was doing my GP training, we were being taught all those years ago that we shouldn't be having paternalistic consultations, and it should be absolutely collaborative. And at the end of the day, it is the patient's body and it is ultimately their choice. So I think it's definitely, we need to remember that a lot more. And I think there's a lot of doctors still out there who are, whether it's fear or it's, scared from getting into legal issues by prescribing HRT, but it's just so frustrating. I often refer off to various specialists for an opinion on X, Y, or Z, and the patient will often chat with that specialist about something, and unfortunately they will often then give a really mixed message to the patient, who then begins to doubt that decision of whether HRT is actually safe. Where do you think that all came from, Louise, and why do you think that it's been so hard to get that myth debunked?
I don't know. I think some of it is because it's about women. I think some of it is because no one's really been that interested in the menopause. In medicine, it's been a bit of a Cinderella specialty. It's really weird, isn't it, that the menopause is due to a lack of hormones. Our hormones are biologically active and go all around our body to every single organ. Yet the endocrinologists, so specialists in hormones, certainly in the UK, aren't interested in the menopause. I know they are more in Australia. The gynecologists over here are the ones who specialize in the menopause, yet they really know a lot about the ovaries and the gynecological organs, but they don't have experience or training in other organs. So then it's sort of left with GPs, and most GPs haven't had adequate training, or they've been brought up like you were in the WHI sort of hangover effect of thinking HRT is so dangerous. But then you've got bodies like the MHRA, our Medicines Health Regulatory Authority, telling us as healthcare professionals and telling us as women that HRT increases risk of breast cancer, clot, stroke, cardiovascular disease. When you look at the insert for the patient, when we prescribe through the BNF, it gives us all these warnings which are clearly wrong and not based on good quality evidence, but no one's prepared to update them. So everywhere you look, it goes against women receiving hormones, and that's why there's so much prescribing of antidepressants and painkillers and other medication. It's like everyone wants to do anything but prescribe natural hormones, which doesn't seem right. But then you also know that hormones are very cheap, so big pharma aren't really involved, and there's less political movement to prescribe HRT because it's cheap. So there's lots of things going on stacking against women receiving hormones.
Do you ever look back? I know I look back on some of the prescribing I did sort of even 7 or 8 years ago. I was seeing depressed women, and I'll put my hands up, I was definitely prescribing them antidepressants, and we were really getting a very mediocre result. And it was only whenever I was beginning to see a pattern that this really didn't actually fit. Often these were women who'd never been depressed or anxious. I had patients who who'd lived in Sydney, for example, their whole life, and then suddenly they were extremely anxious driving around Sydney. They felt they couldn't drive around anymore, or women who had really high profile jobs. They'd always chaired board meetings, and suddenly they couldn't do it anymore. And it just seemed so bizarre. We just really couldn't pinpoint what was going on, and they didn't respond to SSRIs. And I have to say, I do look back and feel like I wish I could go and get some of those women and say, oh, I'm really sorry, but I actually just didn't have the knowledge, and I would probably treat you a bit differently at this point in my career. Have you got any feelings about that?
I've got very strong feelings. I did, a rheumatology job. I did a neurology job. I did a psychiatry job. I did all these hospital medicine jobs, and never once thought about the women coming in thinking they could be menopausal. And there are a lot of women. And I spoke to someone yesterday actually who works in casualty in an A&E department, and she said, gosh, I'm thinking about all these women who present with chest pain, with palpitations, with panic attacks, with migraines, with urinary tract infections. No one's thinking about hormones. And I feel that when you see a woman, regardless of their age, actually, whether they're young or old, or in their late 40s or 50s, we should be saying, could hormones have a role here? Because I do sometimes dream and fantasize about what the world would look like if every woman who needed her hormones back, both systemically and vaginally, had them, because there would be a lot less suffering and there would be a lot less diseases as well. So I wish I could go back in time, because I absolutely have neglected women because I didn't know, I didn't realise. But now I know. It's so unfair that others don't know as well.
I agree. I'm thinking about another patient that I saw who kept presenting to me, and she was absolutely convinced, first of all, that she had a brain tumor, and then she was also then convinced that she had dementia. And she had sort of reasonable reasons to be potentially jumping to those conclusions, but whenever it boiled down to it, we did go down a route of MRI scans of brain and all sorts of things. But in actual fact, once I started her on HRT, within 3 months, things were really quite transformed. So I definitely would nearly love to go back and audit some of those old consultations, but all I can do is sort of learn and move forward. But it is definitely really frustrating. And as you say, all those women that I see in their 70s and 80s with recurrent UTIs just constantly come into me with little pots of urine. I've got another UTI, I've got another UTI, I've got another UTI. I think, gosh, this could have been managed so differently. But definitely, you definitely feel like a bit of an outlier as a doctor at the minute still in Australia, because not a lot of doctors are prescribing HRT, and a lot of people have big exclusion lists of who they won't prescribe to. And I know that you end up seeing a lot of people like who've had breast cancer, or who come from a family history of breast cancer and things like that. And you end up having to approach that and look after those patients because they can't find help elsewhere. Is that something that's becoming a bigger bit of your caseload?
Yeah, it is, because actually the more women find out, the more they realise they want to make a decision that's right for them. And actually there's very few contraindications to HRT. I don't actually think there's anything in medicine, in any aspect of medicine, that you can say absolutely no to, because we always have to look at benefits and risks, but we actually have to put the patient central. And if you think of consent and patients, they can consent to a treatment or an operation that actually might not be right for them, but that's what they want, or they might refuse treatment if they're consenting adults. And so that is really important with anything we do in medicine. And we can't use our own preformed ideas and judgments against or for those women. And so, for example, women with a family history of breast cancer, there's no reason that they can't have HRT, because they might have an increased risk of breast cancer because of their family history, but taking HRT won't increase that risk further. So that's very reassuring for those women. Women who've had breast cancer is very, very individualised. But the women we tend to see in the clinic who've had breast cancer, they've often had breast cancer many years ago. Often they've had estrogen receptor negative breast cancer. But they come and say, do you know what, Dr. Newson, I'm just existing. I'm not living. I don't want to die lying down. I've got lot more living I want to do. And many of these women had HRT before, or they had periods before, and then they've had this awful menopause. And so then they say, well, I would like to try HRT because I'm actually more worried about my risk of osteoporosis than I am about my risk of a recurrence, which I know I might get regardless. And so often then we do try hormones, knowing that there might be a risk of recurrence, but also knowing that there are benefits for those women as well. And then they decide whether they can continue or not. And a lot of women do continue. We follow the women up. We've got an audit process where we follow them up, and actually we've a lot of these women have good outcomes actually, and I think going forwards they probably might have less recurrence, who knows, but actually they're making the decision, whereas just to be told no you can't. And actually some of the drugs that these women are given, like the aromatase inhibitors, strip every molecule of estrogen from their body, so sometimes actually just changing that drug or stopping the drug rather than giving HRT is enough for those people. And it's often now, oncology services, certainly in the UK, are very stretched and very limited. So I saw someone recently who'd been put on an aromatase inhibitor. She'd had a very early stage, low grade breast cancer. She'd had curative or probably curative surgery, but was told, oh, you might as well just go on this aromatase inhibitor for 10 years. 10 years is a long time with very little risk reduction. And we know that a lot of these medications, including tamoxifen, we're treating the majority of people who will never receive any benefit from them. The minority might have a reduced risk of recurrence, but actually if you look at like the predictor, you'll see that most women don't benefit from endocrine treatment if they've had an early grade and stage breast cancer. So just allowing women to be more involved in their decision making, I think is so important.
Yeah, I think you and I talked about this in Australia when you were visiting, but I have BRCA1 and have had my bilateral mastectomy, and I had that joyous experience of going from pregnant to menopausal, which was not fun. But it was interesting. Again, I had these sort of conflicting teams who looked after me, where they were very reluctant for me to have HRT. And I also understand I lived in quite a close-knit community, and various surgeons and oncologists and who were looking after me had also looked after members of my family who had died quite young. So there was that kind of realism to the whole situation. But I also look back and think, what are going to be the implications, because I didn't have hormones for quite a significant number of years, and I do wonder. And I went down pathways because of joint pain and things, thinking, oh, did I have lupus and all sorts of things. But in fact, in hindsight, really looking back, it probably was just the lack of hormones, really.
And that's what's very difficult.
Yeah, absolutely. So whenever someone comes to see you for hormone replacement therapy, where do you begin? Do you start mostly with estrogen and progesterone, or are we going with testosterone, or where do you begin?
Well, it really varies actually. Individualized consultations are the most important. We usually start with HRT, so estrogen and progesterone if someone needs progesterone, but increasingly the conversations are about testosterone as well, and it's an independent hormone. The guidelines say that if women still have reduced sexual desire despite taking HRT, we can consider testosterone, which is usually what we do. But sometimes I see women who are perimenopausal. They tell me they've got zero libido and they have no energy, they have low mood, they're really exhausted, and they're very keen to try testosterone at the same time. And I don't think that's a problem, actually. We don't have evidence to say that's right, but lots of things we don't have evidence, but we have a lot of clinical experience and our clinical evidence as well. And we know it's not harmful having your own hormone back. So it depends on the individual, really. But increasingly, certainly in the UK, people are understanding the benefits of testosterone as well, which I can only think is a good thing, really. It's a lot safer. It must be a lot safer having your own hormones than having other drugs. And a lot of people we see are on antidepressants and other drugs as well.
And in your experience, how long would people normally have to wait before they would feel the benefits of
So patients Patience is a virtue, actually. Most of us start HRT and want to feel better overnight, and it absolutely doesn't. Estrogen can work quite quickly for some people, but some people it takes longer. So we always say you've got to try at least 3 months. Testosterone can take 3 to 6 months. So you have to be patient. But actually, about a third of people we see in our clinic are already on HRT, and a lot of the time their doctors or their gynecologists have said, oh, your symptoms can't be due to the menopause because you're on HRT. Well, they're not on the right dose and type. So it's adjusting the dose and type is really important as well.
And how soon would you change the dose, Louise, with your patients?
So usually when we review people, we often obviously prescribe estrogen through the skin as a patch or gel because it's the safest way of having it. There's no risk of clot. And then we quite often do a blood test to see how it's being absorbed because the skin is a barrier. So different people often need different doses just to get into the bloodstream. So we assess symptoms and we often look at blood tests as well. So it can, and then when people are more stable, we just review them every year. Sometimes people change the dose themselves a bit. So if people are perimenopausal, they're still producing their own hormones, but not as much as when they were younger. So just before their periods is when naturally hormones are slightly lower. So some people might use a slightly more estrogen on those days because as women, we're quite in tune with our hormones. So it's working together with our patients is really important.
Louise, can you explain why tablets are not as great an option or not as safe an option as using the gel or the patch?
Yeah, so there's a couple of things there really. There's different types of tablets, as you know. So the old study, the WHI study that everyone still harps on about, was using tablets containing conjugated equine estrogens, which is actually estrogen derived from pregnant horses' urine, which we don't tend to prescribe. The HRT we prescribe is derived from yam plants, which is a lot nicer. But they also were combined with a synthetic progesterone called medroxyprogesterone acetate, which we know has some small risks, only small, but the small risks include small risks of heart disease and thrombosis as well. So the tablets now we prescribe are usually a body identical estrogen and also the natural progesterone. So natural progesterone, the micronized progesterone, is usually a tablet, and that's very safe. And it doesn't have the risks of clot and heart disease that the older types of progesterone do. There's a theoretical risk of clot when people take estrogen as a tablet because it gets metabolized by the liver and cannot activate our liver clotting factors. But actually, the natural estrogen hasn't been shown to have this risk. So we don't know whether it does or not, but it's still very low. So some studies will say, well, the older types of HRT have a double risk of clot, which sounds really high. But most of us, our risk of clot is very low. So doubling a low risk is still low. Some women find that the patches or gel don't absorb properly, they still get symptoms. So we do have some patients that take tablets either on their own or with using a transdermal preparation. So I don't want people to think that they're not good, but it's nice to have a safer alternative for many women. But even the tablets are still good for many women.
Why do you think women are reasonably happy to take things like the contraceptive pill, but yet there's such a fear around hormone replacement therapy, which in theory is probably more of a natural hormone versus the contraceptive pill, which tends to be synthetic? Why do you think that is?
I think it's due to lack of knowledge, actually, because people are waking up and realizing Kate Muir, who I work very closely with on the Davina documentary, has just written a book which is coming out soon about the pill, and that's going to allow people to know a bit more. And some of you might listen to my weekly podcast, and I did one with my oldest daughter, Jessica, a few weeks ago, and she is talking about her knowledge about contraception and hormones, and she has some PMS and she uses the estrogen patches because why would she want synthetic hormones in her body? And I think a lot of younger generations are not taking the contraceptive in the same way because they didn't realize the difference. And even as a doctor and a medical student when I was young, I didn't know the difference. And I think some of the contraception specialists don't know the difference as well. It seems nonsensical that we're harping on about these risks of HRT, which are low dose. They don't even work as contraception because they're low dose. Yet contraceptives are being handed out like Smarties without warning anyone about risks. It just doesn't make sense. The women who take contraception are biologically the same as women who take HRT. So it just is so incongruous. It drives me mad.
Yeah, it's bizarre because wouldn't you think that if it was all being related to being given exogenous hormones, then we should have masses of young women all with breast cancer, for example? It just doesn't make any sense.
No, absolutely. And also, if you think when the WHI study came out so long ago now, over 20 years, the incidence of breast cancer was about 1 in 12. HRT prescribing has more than halved, as you know, yet breast cancer incidence is now 1 in 7. So it's more common, far more common. Yet it can't all be related to hormones, otherwise we would have seen a decline. So it doesn't make sense. You're right, and that's where I think having a pathology degree where I go back to basic science and look, well, what are the roles of our hormones? And actually, what's very interesting is our hormones, estrogen, progesterone, and testosterone, are also produced in our brains. They're not just produced in our ovaries. So it is nonsensical just to talk about it as an ovarian problem, because it's not.
And do you think that's why we have all these symptoms like brain fog and memory issues and depression when we're going through the perimenopause and menopause? Do you think that?
Yeah, absolutely. Yeah, and we don't know, we can't measure the amounts of hormones in our brains. Obviously, when we do a blood test, it doesn't tell us what's going on in our brains. And interestingly, if someone has a brain injury, like a stroke, one of the first things that happens is our brains produce more estrogen because it's very anti-inflammatory and works as a neurotransmitter, and the testosterone actually helps build our nerves. It helps build the myelin, the protective conducting sheath of our nerves. So there's so much we don't know, and we've had so little research actually, and no one's been interested in hormones because everyone said it causes breast cancer. So we've got 20 years of research to catch up on as well, which is really frustrating, isn't it?
Is there anyone doing it? I mean, is that an anti-inflammatory effect then why people get things like tinnitus and the joint pain, like all those sort of bizarre symptoms that seem a bit unrelated, or the burning mouth? Do we think that that's like an inflammatory pathway?
It probably is, yeah. There's inflammation is a really big thing. So when inflammation isn't right in our body, so if our inflammatory cells aren't working properly, we get this pro-inflammatory state. But also a lot of it is due to nerve function, so our physical nerves. So if our nerves aren't transmitting signals properly, or our brain isn't receiving those signals or can't process them properly, then you can get these other symptoms, and that will often be related to our hormones not working properly in our nervous system.
And whenever it comes to things like, I'm sure it's probably similar in the UK, but in Australia, there's another peak of suicide in women in their 40s and 50s. And I have to say, I have to think that it has to be in some way related to these women that I'm also seeing who've suddenly got depression or anxiety, or who are leaving their jobs or kind of giving up on their careers, or unable to have an intimate relationship with their partners. Is that something that you see in your clinic as well?
Yeah, we do. We see a lot. A lot of women we see actually have had suicidal thoughts, sometimes have had suicide attempts. They're often under psychiatrists, they're on heavy duty drugs, and no one's thought about their hormones. And actually, when they have their hormones back, often with testosterone, they can reduce and sometimes stop some of these drugs. We are funding a PhD student in suicide prevention, and some of the preliminary results are very revealing, but also very sad as well. We do a lot of training with psychiatrists, and in January we're going to have a psychiatrist working with us in the clinic, which is great, because not everybody who's depressed has a hormonal issue, and not everyone who has a hormonal issue is depressed. And there are some women who have both hormonal issues and clinical depression or a psychiatric illness. But we need to understand more. We can't just ignore the effects of hormones on our brains.
What about, there's obviously menopause and perimenopause has exploded, and there's Facebook groups and Instagram people offering all sorts of things to help doing various exercise programs or natural ways to balance your hormones. And I noticed that the NICE guidelines, and for anyone in Australia who doesn't know what that is, they're sort of very well considered guidelines that are used in the UK to really direct care. But they've come out recently talking about using cognitive behavioral therapy, I think, as one of the first line treatments. And certainly I'm a big fan of cognitive behavioral therapy, not dissing psychology or CBT, but I'm really struggling to understand how you're meant to be using psychology to stop someone having, for example, vasomotor symptoms like hot flushes. What on earth is the thinking? Do you know?
Yeah, so their press release was very clear that CBT can be used as an alternative to HRT. And there's so many things that I think are wrong about that, because firstly, it's not a condition that we can talk our way out of. And actually, how is CBT going to improve the strength of our bones? We know taking HRT reduces risk of osteoporosis, for example. And we know that the menopause is caused by low hormones. So in medicine, we should treat the underlying cause. But actually, there are lots of psychological treatments that might help some people, and CBT is one of them. But actually, having a cup of tea and sitting with a friend and talking can be helpful as well. But I wouldn't suggest doing that instead of hormones. So it's just been taken too far, actually, and we're going back in time. How are we going to think our way out of the tinnitus or the burning mouth or the vaginal dryness? It's actually really derogatory to women to think that we can cure ourselves or just be patted on the head with a talking therapy. Like you say, I've got nothing against CBT, but why single it out as the sort of main alternative? It doesn't make sense. And actually in the UK, it's impossible to access CBT anyway. There's often more than a year waiting time, whereas actually to prescribe HRT takes about 3 minutes. So there's so many reasons that it's not right, but it's only a consultation document. We've registered as a stakeholder, so if anyone does want to comment, you can go to comments@newsonhealth.co.uk and put a comment, and then we'll anonymously put everyone's comments forward to NICE. So I'm hoping that by the time it's a proper guideline, it won't have those recommendations.
Louise, I know that we're running out of time. I just want to say that I would love at some stage for us to have another chat, because there's a really big group of women who go through their menopause at a very, very young age. Some people might be quite shocked by how young that may be. I think you've had a couple of teenagers, is that right?
Yes, we've had quite a few actually who have been diagnosed as, well, they haven't been diagnosed, that's the problem. They've had symptoms as a teenager, and it's taken many years to be diagnosed and receive the right treatment. Really important. About 1 in 30 women under the age of 40 have an early menopause, and a lot more will be perimenopausal. So a really important group that are often neglected.
Well, hopefully we can have a chat about that, because I know there's definitely lots of people really interested. So thank you so much for your time. Just to finish, I just wanted to ask you one quick question, which we ask all of our guests. If you could tell your 20-something self, I know that you've got 3 daughters, so is there anything that you've learned, particularly in the last few years, that you wish that you had known, or whatever you think that might change how you are today, or what you wish you'd known?
Yeah, I wish I knew what hormones were when I was younger. I wish I knew the importance of them in our bodies, and I wish I knew how safe natural hormones were. And I wish I had that information that I could not just know myself, but I could share with others.
Well, thank you so much, because you are definitely a trailblazer, and you talked about that you've always struggled to find someone to look up to or whatever, but we all, you've got a big fan club here in Australia. There's a big group of us doctors, and we all fangirl about you. We think you're amazing, and we appreciate so much the time and effort you put into distilling so many clinical papers for us, explaining stuff in really simple, understandable language. So we love you.
Oh, very kind. Thank you. And thanks for inviting me. It's been great.
If you enjoyed this episode, I'd really love you to leave a review or share with someone who you believe would benefit from hearing this conversation. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.